All right, before we go ahead and get started with this morning's session, though, I'd like to take a moment to brief you on one of the sessions this afternoon. You'll see in a moment why I'm taking a moment to do this. The session titled Mock Suicide Fatality Review Meeting Demonstration, the one that's from 2:40 to 4:10 p.m. The reason is I always like to give a disclaimer for these types of sessions, especially those who may have some sort of lived experience with suicide or any sort of connection in that regard, because what you're going to witness actually at the end of the day is kind of a culmination of the entire day. You're going to look at a meeting in progress, an example of what one of these Suicide Fatality Review Board meetings actually look like. And for those who have not participated in any of these fatality reviews, you'll see that some of the language might seem a little harsh, just because again you're talking a little bit more matter of fact because you're reviewing the actual circumstances surrounding the decedent and the death. So the reason again is that I'm talking about this is just to give you an idea of what to expect this afternoon. And if you need to excuse yourself for any reason, please feel free to do so. Again, we have that wellness room in Morgan 3, which is just right down the hallway. With that being said, though, again, it's not meant to be emotionally activating or triggering in any way, shape, or form. We always just like to give those types of disclaimers. And we'll get another reminder as well right before the session actually starts this afternoon, too. However, we believe that this session is extremely beneficial just because, again, you can actually see in real time kind of what this will look like, right, in action. But in your folder, you can get an idea about the case that will be reviewed by taking a quick look at the toxicology report and the coroner's report, which are in your folder. Again, if you have any other questions about that, you can come up to me at any point in the day, and I'm happy to talk to you a little bit more about what that's going to look like. But with that, we'll go ahead and actually get started with the session at hand here. So thank you for joining us for Beyond the Numbers, the Ohio Department of Health and Suicide Prevention. Before we get started, I'd like to remind everybody of the requirements for receiving continuing education credits or a certificate of attendance. At the end of the session, I'll read off a 4-digit code, which you will need to be recorded on the CE certificate that you have for today's event. And you'll find additional instructions on the front of the CE certificate available at the registration desk if you need extra copies there. If you didn't pick up a copy when you checked in this morning, we have extra copies. Please be sure to complete the post-event survey before you leave today, so you won't do this at the end of every session. You'll do this at the very end of the day today. But with that, we can go ahead and officially get started here. Let's welcome Dr. Mary DiOrio, Dr. Abby Hagemeyer, and Socrates Tuch from the Ohio Department of Health to begin their presentation. And we'll let them introduce themselves to go ahead and get started. So thank you.
Thank you. Good morning, everyone. I'm pleased to be with you today and so happy to see so many individuals who are here and sharing in this important work. From a professional standpoint, suicide and suicide prevention are key priorities from a public health standpoint. And from a personal standpoint, I've had some friends who've had family members who have died by suicide. And so both professionally and personally, I am committed to doing whatever we can to eliminate suicide. As you can see from the slide, I'm the medical director. My name is Mary DiOrio, and I'm the medical director at the Ohio Department of Health. I've been back in this role for almost a year now. I had been with the agency for 16 years, including 2 years as medical director from 2014 to 16, and I left to work at 2 large health systems in Central Ohio for a couple of years, but I miss public health. And I miss the work that we do and the mission that we do, including work like this. And so I was just really overjoyed when I could come back to the health department in December of last year as the medical director. I have also, my training is both in family medicine and in preventive medicine, and both look at how health impacts are from how our health is from other impacts. The family medicine view is from how just being in our family impacts our health, right? Just where we grew up, who we're around. So kind of a micro view of impacts of health. And then preventive health is looking at the population view, knowing that our health is impacted by our population. I also have an MPH in epidemiology, and we will have an expert in epidemiology coming later and talking about data. And what we use the data for is to see, what kind of the conditions are, what led them to be the way they are, and then we can inform our public health policies on how we can improve them and what we need to be doing about them. So let's get started. I'm going to have to multitask. Okay. So we're going to have a team approach here, as you heard. I'm going to start by providing you with updates on the statewide initiatives that we are implementing at the Ohio Department of Health to prevent suicide. And then Abby Hagemeyer is going to walk through the data. And then Socrates Tuch will provide an overview of the Ohio Revised Code as it relates to the Suicide Fatality Review Committees. And I have no financial interests or disclosures to disclose, relations to disclose. So how do we define our public health priorities in Ohio? Every couple of years, we develop a state health assessment. And the state health assessment is a comprehensive and actionable picture of health and well-being in our state, in Ohio. The purpose of the state health assessment is to inform and identify the priorities for the next document that's called the State Health Improvement Plan. The other purpose of the State Health Improvement Plan is to encourage partnerships with sectors beyond health to address upstream factors. And we commonly call these either social determinants of health or social drivers of health that impact health. And so these are going to be things like transportation, food, housing, community safety, and financing. Now, the State Health Improvement Plan in Ohio focuses on improving 3 priority health factors and 3 priority health outcome areas. And the factors are community conditions, health behaviors, and access to care. And the priority health outcome areas are mental health and addiction, chronic disease, and maternal and infant health. And suicide prevention is a priority within the mental health and addiction-focused area. ODH has dedicated staff for this work. And they're located within our Bureau of Health Improvement and Wellness, and specifically within the Violence and Injury Prevention section. And these include a suicide prevention coordinator, an epidemiologist, and a social science program evaluator. While the Ohio Department of Health is the author and lead agency on the State Health Improvement Plan, to be able to address the priority areas within the plan, including the priority area for suicide prevention, we know that collaboration with many, many agencies and organizations, including all of you in this room, is needed to achieve the goals established within the State Health Improvement Plan. So what are some of the initiatives that the Ohio Department of Health is doing for suicide prevention? The Ohio Department of Health does the administration for the Ohio Youth Suicide Coalition, and the Ohio Youth Suicide Coalition was formed in 2022 and follows the State of Ohio Youth Suicide Strategic Plan, which many community partners were involved in creating. The Ohio Youth Suicide Coalition is a multi-sector partnership with state and local organizations. It meets bi-monthly and is working to promote and share resources and ideas to help our partners implement suicide prevention activities for youth ages 10 to 24 in their communities and across the state. And if you haven't heard of this coalition but would like to be a part, please let us know and we can get you signed up. The Ohio Suicide Prevention Foundation is partnering with ODH to form a work group for the adult male population. The adult male work group will create an action plan that involves collaboration, data collection, communication, and implementation of activities. And this will give Ohio an opportunity to expand approaches statewide while still prioritizing high-burden counties. Look for information about joining this group near the end of this year or at the beginning of next year. There are several bureaus within the Ohio Department of Health that participate in the monthly Ohio School Safety and Violence and Prevention Work Group that's led by the Ohio Department of Education and Workforce. And this work group discusses safety and violence prevention for schools. And it addresses bullying, harassment, violence for students. This group has created modules for the schools to utilize, including one to recognize the signs and symptoms of suicide and how to respond. And then lastly, the Ohio Department of Health has participated in work regarding the 2024-2026 Suicide Prevention Plan for Ohio. The Ohio Suicide Prevention Foundation and the Health Policy Institute of Ohio facilitated the creation of the state plan with funding from the Ohio Department of Mental Health and Addiction Services. And ODH had several members involved in the advisory team for this plan, and as well as with our state's first suicide prevention plan that was released in 2020. And this plan was released in 2024. The Ohio Department of Health secured its first funding at ODH for suicide prevention with the Comprehensive Suicide Prevention Grant. And this 4-year grant includes multi-sector partnership planning, surveillance, evaluation, and implementation of evidence-based strategies with 2 disproportionately affected populations: youth, ages 10 to 24, and adult males, ages 25 to 59. Now, much of the youth work will be completed by the Youth Suicide Prevention Grantees in combination with the group I mentioned, the Ohio Youth Suicide Prevention Coalition. The male work will be completed through a contract with the Ohio Suicide Prevention Foundation, who will form, as I mentioned, the adult male work group, and they will focus on selected evidence-based strategies while prioritizing counties with highest burden. And those counties for the adult male work group that will be prioritized include Lucas, Montgomery, Hamilton, Clark, Marion, Richland, Cuyahoga, and Mahoning. On March 1st, ODH released its first youth suicide grantee program focused on ages 10 to 24, and 6 grantees from high-burden counties are able to dedicate funding to address youth suicide in their communities. Each funded partner has selected evidence-based strategies that involve community-based healthcare system and upstream approaches, and all of which of these approaches were required to come from CDC's Suicide Prevention Resource to Action Guide. At this time, Allen, Franklin, Delaware, Licking, Huron, and Portage counties are funded. For year 2, which just started in September, 5 of the 6 are also working to enhance their local suicide fatality review committees. Activities selected include trainings to identify and support people at risk through question, persuade, refer programming, and virtual hope box, creating protective environments through safe storage practices, safety planning and counseling on access to lethal means, and teaching coping and problem-solving skills for year 1 college students to promote resiliency. And each funded partner is required to work very closely with their local suicide prevention coalition and their Adam H. board. And lastly, the Ohio Department of Health was awarded a grant from HRSA in 2023 to establish the Pediatric Mental Health Care Access Program in Ohio. And this program provides pediatricians and other child and adolescent primary care providers training in mental health and direct access to mental health experts via teleconsultation. So specifically, pediatric mental health care teams will provide the teleconsultation, the training, the TA, and the care coordination support for pediatric primary care providers so that those providers can diagnose, treat, and refer as needed any child with behavioral health conditions. The Ohio Department of Health is contracting with the Government Resource Center at The Ohio State University and the Ohio chapter of the AAP to plan, implement, and evaluate the various aspects of this project. And there's going to be an advisory committee that meets regularly to discuss this work as well. And the Public Health Fund of Ohio was created in July of 2020 to support ODH's mission to advance health and well-being, and it also supports ODH's strategic, the State Health Improvement Plan that I mentioned. And they do this by providing funds, and 7 local suicide coalitions were funded by the Public Health Fund to expand evidence-based strategies in their communities. And these coalitions included the counties of Cuyahoga, Darke, Hamilton, Highland, Licking, Logan, Lucas, and Pike. The Ohio Department of Health and the Ohio Department of Mental Health and Addiction Services worked with stakeholders throughout Ohio in a work group to create, and I think you all have it, the Suicide Fatality Review Manual to help guide existing suicide fatality review committees and new communities who wish to establish a suicide fatality review committee. The Violence and Injury Epidemiology Surveillance section at ODH releases a weekly summary to key state partners about Ohio Emergency Department visits for suspected attempts and suspected suicidal ideations. And this data can be used as an indicator for trends in suicide. And the Ohio Department of Health worked with community-based partners to create a training video for guidance on establishing a suicide fatality review committee. ODH also developed guidance for those with established Suicide Fatality Review Committees for their annual reports, and both of these can be found on the ODH website, these guidance materials. And as a reminder, if you have an active SFR committee, the previous calendar year's annual report is due to ODH by April of the following year. And lastly, I want to highlight a project that we've done in partnership with the Ohio chapter of the AAP. In 2022, we entered a partnership with Ohio chapter of the AAP to implement a quality improvement project for behavioral health screenings for adolescents. This is the Store It Safe program, and it's part of our core injury prevention grant that we get from CDC. The Store It Safe Quality Improvement Project involves recruiting pediatric and family medicine providers across Ohio with high-burden youth suicide counties and training them to screen for both depression and suicide, in addition to providing counseling. The project empowers providers to identify and address the means of suicide at all encounters with adolescents. Providers are trained on using the tools as well as how to provide resources for discussions with all families to ensure that there is a plan in place for times of crisis if needed. Providers are given safe storage options such as lock boxes and gun locks to offer all caregivers, along with educational information on safe storage and where to find resources. And there have been 2 waves of this project, and a 3rd wave is currently being actively recruited. In Wave 2, Ohio AAP partnered with 19 practices who screened 2,749 youth for depression and 2,622 for suicide. The caregiver survey indicated that only 15% of families with a pediatric provider and 23% of families with a family medicine provider had ever been asked outside of that appointment about these questions. In addition, several screenings during this project time period resulted in treatment plans being implemented. Initially, the providers were only doing the screenings at annual well visits, but they moved to doing screenings at every visit. So clearly this project is making a difference, and we will continue to see that as the 3rd wave of the project will be undertaken. And now that we've covered the various initiatives and statewide activities being implemented, I want to turn the presentation over to Abby to discuss the data.
Hi, I'm Abby Hagemeyer. I serve as the Data Administration Manager for the Violence and Injury Epidemiology and Surveillance section at the Ohio Department of Health. And I am pleased to have this opportunity to provide an update on suicide deaths among Ohioans today. All right. So this slide shows the number and age-adjusted rate of suicide deaths from 2014 to 2023. In 2023, 1,777 Ohioans lost their lives to suicide. This was a 1% decrease from 2022. From 2022 to 2023, the age-adjusted rate of suicide deaths depicted by the red line there decreased 3% from 15 to 14.6 suicide deaths per 100,000 population. So this slide shows the number of suicide deaths by quarter and year from 2021 to 2024. Please note that the 2024 data is preliminary and subject to change. In 2021, we saw an increase in the number of suicide deaths each quarter. In 2022 and 2023, the number of suicide deaths by quarter remained relatively stable, ranging from 434 to 463 deaths per quarter. Here we're looking at the same data as the slide before, but this visual allows us to more easily compare the same quarter across years. So as you can see here, there were 438 suicide deaths in quarter 1 of 2024, which is depicted by the red bar, and that was higher than the number of suicide deaths in quarters 1 of 2020, 2021, and 2023. This slide shows the number of suicide deaths by mechanism and year. We can see that firearm is the leading mechanism, accounting for more than half of all suicide deaths each year. From 2022 to 2023, the suicide deaths by firearms and suffocations did decrease. We saw a 1% and 7% decrease respectively, while the number of suicide deaths by drug poisoning increased by 11%. The next several slides, we will look at the percentage of suicide deaths by mechanism and selected or specified demographic group for 2023. Here we can see that mechanism does differ by sex. While firearm was the leading mechanism of suicide deaths among both males and females, it accounted for 62% of deaths among males and 41% of deaths among females. Drug poisoning also differs by sex. It accounted for 26% of deaths among females while only accounting for 6% of deaths among males. In 2023, firearm was the leading mechanism of suicide deaths among all age groups shown here. Those aged 65 and older had the highest percent of firearm-involved suicide deaths at 75%. Those aged 35 to 44 had the highest percentage of suffocation-involved suicide deaths at 37%. And the percentage of suicide deaths by drug poisoning peaked between the ages of 45 to 54 years of age at 16%. In 2023, the percentage of suicide deaths by firearm was highest among the Black non-Hispanic population, followed by the white non-Hispanic population, accounting for 68% and 58% of deaths respectively. The percentage of suicide deaths by suffocation was highest among the Asian Pacific Islander non-Hispanic population, accounting for just over half of deaths. And the percentage of deaths by drug poisoning was highest among the white non-Hispanic population, accounting for 10% of deaths. This slide shows the rate of suicide deaths by age and year from 2020 to 2023. In 2023, Ohioans 45 to 54 years of age had the highest rate of suicide deaths, 20.1 per 100,000 population, and this was followed very closely by those aged 25 to 34 years of age, and their rate was 19.9 per 100,000 population. From 2022 to 2023, Ohioans aged 55 to 64 years had the largest increase in the rate of suicide deaths. This was a 10% increase, followed by those 45 to 54 years of age, which saw a 4% increase. Ohioans aged 35 to 44 years of age saw the largest decrease in suicide deaths. This was an 11% decrease, followed by those 10 to 24 years, which saw a 6% decrease. This slide shows the number of suicide deaths by age and sex in 2023. Males, depicted by the blue bars, are disproportionately burdened by suicide deaths, accounting for 81% of all Ohio suicide deaths. Except for the 10 to 14-year age group, males had a higher number of suicide deaths in the other age groups shown here. And for both males and females, those 25 to 34 years of age had the highest number of suicide deaths in 2023. This is a similar slide, but now we're looking at the rate of suicide deaths. Among males, those 75 years and older had the highest rate, and among females, those 45 to 54 years of age had the highest rate of suicide deaths. This slide shows the age-adjusted rate of suicide deaths by race and ethnicity for 2023, from 2020 to 2023. The white non-Hispanic population had the highest rate of suicide deaths during this time period. And from 2022 to 2023, the Asian Pacific Islander non-Hispanic population was the only race ethnicity group for which the suicide rate increased. They saw a 12% increase during that time period. From 2022 to 2023, the suicide death rates among both the Black non-Hispanic and the white non-Hispanic population decreased 2%, while the Hispanic population decreased 6%. And here we're looking at the age-adjusted rate of suicide deaths by race, ethnicity, and sex. Again, here you can see the white non-Hispanic males continue to have the highest rate of suicide deaths. And from 2022 to 2023, Black non-Hispanic females and white non-Hispanic females had the largest decreases in the suicide rate. We saw a 6% decrease in both groups. And the rate of suicide deaths among white non-Hispanic males decreased 1%, while the rate among Black non-Hispanic males remained unchanged from the previous year. And finally, this slide shows the age-adjusted rate of suicide deaths by county of residence from 2020 to 2023. Vinton County had the highest rate of suicide deaths, which was 31.6 per 100,000 population. And this was followed by Harrison County at 30 per 100,000 population and Monroe County at 29.2 per 100,000 population. Of the 16 counties that had the highest rates of suicide death, which are depicted by the darkest blue, 14 were rural, 11 were rural Appalachian, and 3 were rural non-Appalachian. And if anybody has questions on data or data inquiries, we have our contact email address up here. And I will turn it over to Socrates.
Good morning. Okay, this is the standard disclaimer. What this translates to, I've never been here. If asked, I never said anything coherent. All right, just as a basic rundown of the statutes, the starting point is going to be your county commissioners. If your county commissioners choose to have a review committee, it must select a health commissioner within the jurisdiction to start the process. If there is more than, it is possible, I'm not going to get too much into it, it is possible to have more than one county covered by the same committee. You know, if that's sort of a regional kind of concept, I'm not aware of a regional concept, we can get into that. But if you are contemplating a regional one, that there are some different aspects that need to be worked out. So, you know, you probably want to have a separate conversation about that because it does trigger some other statutes. By the way, if you're already already have one in place, the statute grandfathers you in, so you don't have to restart the process. So that's an upside. The health commissioner basically starts with the chief of police or the sheriff. The sheriff obviously for the whole county, but the chief of police for the municipality, the largest municipality in the county. So that's the one that's designated by the statute. The executive director, not the ex-director, but the executive director of the Adam H. Board or similar in the county. A public health official, that's an additional public health official to the health commissioner. Don't know why the General Assembly chose to do that, but they did. So you have 2 public health persons on there. And then the physician. The county coroner is an optional individual. The county coroner can be invited to attend, to participate as a member, but the county coroner does not have to participate. It is optional for the county coroner. Providing data is not optional. We'll get into that later. But the participation of the county coroner is optional. The majority, and this is a question that has come up, the majority of the members can choose to invite other individuals to participate as part of the committee. So they, not just a one-time thing, but can be standing members of the committee. But the majority have to vote to have that other or additional individuals to participate. No one is paid. Expenses can be reimbursed. Actual expenses, we'll talk about if you want to get into that. Actual expenses are that are incurred can be reimbursed unless the employer has already included that as part of the person's pay. If it is a part of the person's job duties, essentially, then that person is not eligible for reimbursement. These are the basic purposes of the committee. You don't need to this is part of your report that will be due in April. And you kind of tick off the boxes. That's the nice thing about the statute. It just kind of tells you what needs to be in the report. You just kind of tick them off. Now, the health commissioner is the chair. Any review has to wait until all legal proceedings about the suicide have terminated, unless the county prosecutor gives you special permission, and it's done on a case-by-case basis. If the county prosecutor gives you permission, then you can review that particular case. Otherwise, you have to wait until all legal proceedings are done. Similar with law enforcement, they have to, if law enforcement is investigating, you still need the permission of law enforcement before you can investigate a case. Otherwise, you have to wait until the investigation is done. Before I move on, for those of you wondering why the difference is that not all investigations may result in criminal prosecution. So if it's just the police investigation and it doesn't proceed to criminal prosecution, then you don't need to involve the prosecutor. So that's the difference. All right, as a committee, you have to establish a secure system for not just reviewing, but obtaining, maintaining, and reviewing all of the data available to you. So everything that you collect on every death is confidential. You have to maintain that in a confidential manner. So part of what you need to do is, if you have electronic records, you have to secure those in an appropriate format. The statute does not tell us what that environment looks like, but if, for lack of a better touchstone, if it's HIPAA compliant, that's probably going to be good enough, okay? I have a hard time thinking anyone would challenge you if your system is HIPAA compliant. If it exceeds, obviously that's fantastic, but anything less than a HIPAA compliance, you might open yourself up to some kind of criticism for not having the material secure enough. Already mentioned the April 1st report. By the way, that April 1st report that's submitted, that's about the only thing that's produced by your committee that is otherwise a public record. Everything else is not available to the public. Right? This report is. So just keep that in mind as you write it. Upon your request, you may obtain a summary of any medical information or other information that you are requesting. The difference between a summary and a copy of the medical record is that it's somebody abstracting the medical record. You can ask, you can come up with a form that says, here's how it's summarized, answer these questions, this is the information we need to know. If you can ask for the medical record, if it's easier for the provider just to provide you a copy of it. That can get a little tricky sometimes. There may be information that is not relevant to your investigation. That's something that you're going to have to deal with if you receive excessive information, because even though it's confidential in your hands, you may have to prune that information from the record before it's reviewed. So the advantage to the summary is that you get only what the information that you need, and you don't have to worry about pruning the information or screening the information prior to giving it to the committee. You can access the confidential information of the coroner report. And if no one provides you the information, that is enforceable in a court of law. You can get the county prosecutor to help you with that, and you can enforce it. One of the questions that comes up is that people get reticent, particular providers, they get reticent about things like HIPAA. You actually do have an exception in HIPAA. All of your work falls under the public health exception. So if you want to write this down, it's 45 CFR 164.512 paragraph B as in boy. I will repeat that. It's 45 CFR, which stands for Code of Federal Regulations, section 164.512, paragraph B as in boy. And if you really want to show off, the statute that authorizes that regulation is 42 USC 1320 D as in dog -7. Also paragraph B. Okay? Trust me, when you throw those numbers at the provider, they're going to go, wow, you must really know what you're talking about. All right, I kind of put these together because statutorily, these are all sort of very similar. If you've read the statutes, they're very short, they're very specific, but the implications of them are very important. Anyone who provides you information is immune from civil liability in state court. Keep this in mind. These are state laws. They are not necessarily impacting federal law. So a civil suit in federal law does not necessarily implicate state law. But in state court, providers are immune from civil liability. I need more caffeine. All right? Your work, you have immunity from civil liability in your work. You cannot be sued in state court successfully. Let me make that statement very clear. In this country, anyone can sue anyone else for anything. The immunity comes at the back end. It means that they can't collect anything from you. And if they can't collect anything from you, why sue you in the first place? Right? It's just a lot of expense where at the end they get zero. That's what immunity means. Okay? So, you are not liable for any of your work. Now, if you exceed the scope of your statutes, if you do work outside the scope of the statute and your authority, you're on your own. Okay, that's on you now. But so long as you stay within the scope of the statutes and your authority, you're immune from liability. What do I mean by that? Don't reach criminal conclusions in your work. Don't do anything that smacks of a criminal investigation. Right? Now you're exceeding your authority. That difference clear? Yes? Good. Thank you. Everything that you do is confidential. Your discussions, your work product, your notes, so long as it's within the scope of your work as a committee member, it's all confidential. It is not subject to public records requests. It's not subject to discovery. You do not have to respond to a subpoena, for example. It's not admissible in court. General Assembly went to a great extent to ensure that there is no way that they can use your work in a state court of law. Federal court, that's a different animal. If you get served with a federal subpoena, you need to have a long conversation with your prosecutor. Okay? Because that's the person who's going to defend you and your work in federal court to ensure that it stays confidential. Federal courts may give some deference to your work and the state law, but federal court is not bound by state law. So keep that in mind. It's a complicated question of federalism. And so you need your prosecutor way at the start end. The day you get served with a federal subpoena, contact your prosecutor. You're going to need that help, and you're going to need it quickly. You can have both a suicide, and an overdose committee. You can have a combined committee. If you choose to have this kind of hybrid committee, all the statutes apply, same work, all the confidentiality. If you read both sets of statutes, they basically parrot each other. One says suicide, the other says overdose. Right? You can have separate committees. You are not required to have hybrid committees, but if you choose to have them for efficiency purposes, you will have to ensure that your membership meets both qualifications. Right? But other than that, you can do the same work. And to that, are there any questions? Yes, ma'am.
So instead of the health commissioner, could it be a designee?
The question is instead of the health commissioner, can it be a designee? And the answer is, to start with, no. It has to be the health commissioner. The statute is very clear about the health commissioner getting the process started. Moving forward, there may be an opportunity to have a substitute or a designee, but you probably always want to rely on the health commissioner to get things moving.
And I have a microphone, so if you want to raise your hand, if you have a question, I can try and run over and grab you.
Anybody? I don't see any.
Wow, we must have done an excellent job.
You were very, okay. You gave him a second.
Darn.
I guess my question is just more related to like the federal involvement. I was just curious, what would be a situation in which the federal law would want to be involved in the fatality review process, where is there something that we would be doing specifically that would then expose us to federal law jumping our door, or I guess what would be would be the situation in which that would become possible?
Well, I can't predict all of them. The question is, if you didn't hear, it's what kind of scenario would trigger a federal court involvement? And I can't predict all of them, but I can think of something along the lines of, if for whatever reason, the suicide or the drug overdose is connected to a federal crime, federal prosecutors might want to see what you're doing. More likely, the federal prosecutors will have other resources so that you may not be the resource. So they may be a little flexible on that point. However, if you, for whatever reason, are the only source of that information, they're going to want to look at it. And again, that's a federal criminal subpoena that may or may not trigger, or there may or may not be federal court deference to state law there, okay? In terms of some kind of civil federal case, if, for example, the suicide or the overdose had a family member that was out of state, then you have diversity of the parties, and someone can sue in federal court in a civil suit or something of that nature because of the diversity. So again, you really want to get your prosecutor involved in that as early as possible, because there may have to be a lot of conversations there with the federal court.
We've run into an issue with partners that their Ohio Revised Code says they cannot share with us. So for example, Child Protective Services, they said that in their Ohio Revised Code, it says they can share information with child fatality review committees, but not we're not listed there. Do you know anything about that?
Conflicts of law are common. So where you have those kinds of situations where you have one agency where you're not carved into their exception, you're going to have to note those, and that's one of the things that you're going to have to put in the report. Those kind of roadblocks, you're going to have to put that into the annual report, at which point we can carry that forward with the possibility of trying to fix it. All right? Never a guarantee in the legislative process, but we will do what we can. You're welcome.
I've seen specific information regarding the overdose annual report, but who is the contact at ODH regarding who are we sending the report to for suicide fatality review?
I'm going to. Oh, that's.
I'm sorry. So our section is the one that collects the annual reports, and I will say something that's going to change, and we'll make sure you get my information and everything, because starting this year, you're going to have to get a passcode to enter your annual report. We're trying to make it a little bit more confidential, but they come to us. There's guidance online about how to do the report, but we're the ones that get them. So we'll make sure that the people that submitted reports last year, which, by the way, only 20, so we might be missing a few. We'll make sure those people in the context we have, we'll make sure that they have the right code, but we're trying to make it just a little bit more secure so that you're reaching out and we give you a specific code. But they do come to the violence and injury prevention section, and one of the positions that we talked about earlier is going to help with our violence and injury epidemiology team kind of look at those annual reports, just since we now just got the funding for those positions, and then trying to come up with some, looking at the whole state, and then what do we do next with that. But it is me, so we'll make sure you get my information. Thank you for everybody that has submitted one. They look very nice. So.
I see you now.
Thank you. I don't know if you'll be able to answer this or not, but maybe you can help direct us. So I'm from Stark County, and we've had significant challenges in moving this work forward when it comes to our SFR, and we have a psych autopsy investigator position as well. And so I guess my first question is, when your local prosecutor has a different opinion of Ohio Revised Code, how can we help with that? I'll give you an example. So when it comes to data sharing, like information that's shared at SFR, we don't talk about the individual's name. And so when we originally had our psych autopsy investigator position, we were hoping that between the health department and the psych autopsy person that they could share information around the decedent so that the psych autopsy investigator could reach out, and they were told they couldn't share that information. So I don't know if, as a psych autopsy investigator sitting on SFR, if they're able to take the work that is shared in SFR and take that to help inform their work, if that makes sense.
Well, let me start by saying, there's an old joke that says, what do you get when you put two lawyers in a room? You get three opinions. Mm-hmm. Okay, and the truth is, differing, reasonable minds can differ on how to read this stuff. Excuse me. So it is possible that your prosecutor is either reading or over-reading or under-reading some part of the statute, or is reading it in conjunction with something else. Not having been part of that conversation, I have no idea. But if that's the prosecutor's conclusion, I suppose we could probably try to have a conversation as a colleague to colleague to try and figure out what the hesitation is or what the concern is. Can I change his or her mind? I don't know. Probably not. I don't know. They do what they do. Ultimately, unfortunately, that's the legal opinion that's going to stand in your county. Mm-hmm. I can't override that. The Ohio Department of Health can't override that. If there's something in the statute that the prosecutor believes is missing or unclear, and we get more than one opinion about that, then that's something you can put in the annual report that we can then take forward and say, well, maybe this isn't as clear as the General Assembly thought it was, and we can try to see if we can clarify that. All right? If it's just your prosecutor, then I don't know. We could, like I said, we could try to work through that, but I can't promise anything.
That's helpful. Thank you.
You're welcome.
I also have a question. So you're hearing a lot about psych autopsy investigators. I have another question about them, though. So the Ohio Suicide Prevention Foundation, we have trained like 70 or so of these folks. Not all are sitting on their current Suicide Fatality Review Board. We are certainly encouraging that, especially around the civil liability piece there, the immunity piece, right? However, I have another question around the compensation piece. Because at first glance, it looks like if these folks, if it's not their regular job, right, if they're doing this kind of as a contractor, right, conducting these kind of outside investigations, but it is a part or it informs the Suicide Fatality Review Board, are they or are they not allowed to receive some sort of payment as a contractor if it does supplement and inform the work of the Suicide Fatality Review?
A contractor for whom?
Let's just say, I don't know, the local mental health board or, you know, just, is anybody allowed to pay these psych autopsy investigators to do this work because it takes some time, right? And it's, a lot of people got this training, but their employers aren't letting them do this as a part of their regular job, right? But they still want to conduct the work because it's extremely valuable. And it goes more in depth than a suicide fatality review, so it would then in turn really help inform the suicide fatality review. But the way reading the statute looks like folks can only get compensated if it's a part of their regular job.
All right. The statute says that members of the review board or the review committee are not paid. There is no pay.
Right.
They can receive reimbursement for incurred costs. That's lunch. That's that kind of, maybe some mileage in that, assuming you have the funds to do that. But no one's getting paid. Mm-hmm. Now, if you contract with someone, then that's a contract negotiation. That is not a member of the committee as a contractor.
And that's why we're encouraging folks to become a member, and we're also encouraging folks to, get their employers on board that this is a part of their regular job duties. But that question has come up from some of the folks, so I just wanted to relay that on their behalf. So thank you.
You're welcome.
Any other questions?
Oh, okay.
Oh, I missed you.
I'm just curious if we can have access to previous reports, or if this is so new that we don't have previous reports to look at.
I'm sorry.
I'm just curious if we have access to looking at previous reports about the Suicide Fatality Review, or if it's too recent, we don't have enough data to look at.
I'm going to defer to Tiffany as to whether there are previous reports to look at. If there are, they're public record, so.
Are you talking, I'm not sure who asked that. Are you talking about a state suicide fatality review? Where I'm not sure what you're asking for. Right. So it's a little tricky with the suicide, because the Ohio Revised Code does not require that ODH puts out a suicide fatality review annual report like they do the child fatality review. And we've only been collecting data for 2 years. I think eventually we'll probably get there, but we don't have enough data to kind of do anything quite yet. I think the first year we got 7 reports, and then this last year we got 20. So we obviously need a little bit more in order to have things. But if you're looking for an example of a report, we might be able to, pull one, get permission from the other county, redact everything, if that's something that you're asking about. Okay.
There's a question way in the back.
Of course. No problem. Hand up, because I didn't see who it was. Sorry.
Stark County. Was wondering, you had mentioned, one of you had mentioned several counties that had grant money available due to their numbers. Is there any plans to kind of broaden that to some other counties?
Okay.
Oh, Tiffany. At this time, we have limited funding through CDC. It was our first dedicated funding to youth suicide. And I did want to explain a little bit why we chose youth suicide in the adult male population. Because when you look at the data, maybe that's not the highest group now. When we originally applied for the grant in 2021, we didn't get it. We applied again in 22. We didn't get it again. See, we don't get grants too. And then the CDC came to us in 23, and they had received more money for suicide. So we had originally applied for youth in that adult male population, and so that's kind of what our application was stuck on. Not stuck on, but that's what we had to stick with for the 4 years, and so that's what we're sticking with. We just started year 2. We would ideally, of course, like to expand it, and that comes with us applying for more grants, which we're always doing, because we understand that it's just a drop in the bucket, right? It's just a starting point right now, but we're hoping with the male work group that we're going to be doing the contract with Ohio Suicide Prevention Foundation. That's going to reach a lot more counties, I think, than the Youth Suicide. The Youth Suicide State Coalition reaches a lot of partners, even if you're not getting the funding. But of course, we're always trying to apply for more grants, and we try to share them out your way too, because we get grant opportunities sent to us all the time that we can't apply for. Like, it's not, we don't have the capacity or whatever. So if you're not a member of the Ohio Injury Prevention Partnership, and I'm saying that because the Ohio Injury Prevention Partner covers overdose. It covers older adults, and child injury. So if you're not a member of that, think about signing up, because we send out a lot of grant opportunities through that organization. And that's the coalition that we also lead. We're trying.
We have time for one more question. Speak now or forever? Okay. That must be it.
All right. Well, I'd like to thank all of our presenters from the Ohio Department of Health. So let's give them a round of applause.